So a couple of questions from the break, one of which was looking at how the ligaments are sufficiently strong to remain attached to the bones. When we think even of a relatively mundane example of climbing on a table to do something and then jumping off again, you have multiple times your body weight going through the knee. So the ligaments and the tendons, we can consider them similar in this example, have a very complex interface with the bone. So where we have a bony surface, such as this, and we have any kind of ligament or tendon joining onto it, the issue we have from our own experience is that we know that bones are very stiff. If we were to feel the back of our heel, you can feel your Achilles tendon, and you can feel that that's very flexible. So at the very back of your heel, you can feel it and you can wobble it. It's like a piece of rope. And so you end up in this very undesirable engineering scenario where you have a very rigid surface and a very flexible surface interfacing with one another. As soon as we put load on the tendon or the ligament, which we will if we jump off the table or if we try to do something, this will straighten, and there'll be a stress concentration trying to pull the ligament or the tendon away from the bone. And needless to say, if we want the cartilage surfaces of these joints to last 70 or 80 years, then it's important that the ligaments do as well. These are finely tuned components, assemblies. If you start having failure of one of the ligaments, then the balance and the clearances between these surfaces is going to be negatively impeded. And so it's important that these interfaces remain as robust as they can. And the body is very clever in doing that. It ensures that there is the maximum cross-section that it can achieve between the two, because the tendon grows into the bone, and so there's an overlap of the two. And the tendon is adapted such that this area here is a lot stiffer than the mid-substance of the tendon itself. And there are remarkable similarities between that and bone. And let's pull up that first of us. Here we go. Can we pull out the plug? Just that one there. Yep. Pull it up to that. Excellent. So we have a very similar problem when it comes to anything that is flexible, much like a cable, and the interface here of a hard USB socket. Now the engineers here have presumably realised that unlike the keyboard, where here we've got the same scenario, if we were to pull this upwards, we can imagine there's a risk of the cable shearing at this joint. If we look at the other end, then the designers here have added in some grommet, some additional plastic that prevents that immediate shearing at the surface. This grommet flexes a little bit so that we have a gradual change from a very stiff structure or a component through to a very flexible component. And that is pretty much what the human body does as well. Oh, thank you. And also a question about the meniscus. The role of the two menisci are in essence to try and stabilize the joint. So they wrap round about 3/4 of a circle each. So it starts here and finishes around the back, and equally the lateral one finishes around the back as well, and it adds stability. If we were to cut through it, we would see that the meniscus effectively is a wedge shape on our knee, and so it stops or constrains the upper surface, the femur, from sliding off the relatively flat tibial plateau. So this is an example of quite how complex this joint becomes. This is a joint that's an exemplar across all of the others in the human body. The knee is unique insofar as it is the interface of the two longest levers. So when we talk about our moment arms again, where we take a multiple of the distance between the pivots and a certain point, when you're dealing with the knee, you know you're at the extreme ends of that because you've got the femur and the tibia and fibula of the lower leg being the longest of any. This creates problems in itself. It means that there is frequently greater load going through the knee than body weight. It also means it's prone to injuries through sport as well. Soccer players, rugby players, to a lesser extent cricket players, but where there is a risk of contact, the knee becomes very vulnerable because whilst it has these ligaments to add stability, any kind of loading from the side in particular means that there is a risk of failure of one of the ligaments. Here we've got an example of a torn anterior cruciate ligament. So that's one of the two that cross over in the knee, the one that inserts on the front of the tibia. And here we see that that is damaged. Any kind of injury of that nature would most likely require surgery and a rehabilitation time of maybe 9 months, if not more. Biomechanically, we can in some way mitigate against those risks. For example, a risk of injury may come from the surface on which you're playing. So if you're playing soccer, have you got the right boots for the right surface? If you don't, then you have a greater risk of greater forces being transferred up through your knee than originally was intended. So we can start to study the knee, much like we can any other joint in the body. And we can quantify again how people move, but not only that, the joints and the bones within those joints. And we can start to systematically quantify forces and moments acting within it. And we can perform two types of analysis, kinematic or kinetic. And again, when we consider just how complicated the human body actually is, we try and make some kind of simplification to ease our ability to accurately come to some useful and meaningful conclusion. Because in actual fact, not that the picture is brilliantly clear, but in actual fact, there is 3 types of movement in the knee. I'm sure most of us could by now work out that the knee flexes and extends. That is, that you can bend it inwards and then extend it back out again. Perhaps less obvious is the abduction and adduction of the lower aspects, the lower bones. Equally, the subtle internal and external rotation. So as you walk, not only are you extending and flexing your knee, but subconsciously there's actually some abduction and adduction, so it moves inwards and outwards, and it rotates internally and externally as well. Such that at the end of one full walking cycle, your knee is, and your lower leg are back in the same position again. So if we consider just the sagittal plane, that's where it's safe to say that the vast majority of the movement happens. The knee can go from full extension, so with it being out straight, to a flexion of about 140 degrees. That's to say that you can't go to 180 degrees flexion, because in essence your knee would be by the side of your hip. So if you were to sit on your feet, you would get about 140 degrees flexion. With various activities that we do, we can see that the amount of flexion in the knee changes. So walking, you would have no need to go anywhere near 140 degrees of of flexion, you normally go to kind of 60, 70 degrees or thereabouts. Climbing stairs, descending stairs, you require greater amounts of flexion because you have to lift and position your foot into the appropriate place to do the activity that you need to. Tying a shoelace, lifting an object, begin to come to the extremes of the range of motion that we're talking about. And again, trivial though some of these aspects may seem, these are strong indicators of quality of life. It's okay walking, but if you can't actually put your shoes on in the first place to go and walk, because any kind of knee motion up to that level starts to hurt, then you have a negative impact on your quality of life. If you can't get to a range that allows you to sit down properly, then that becomes problematic too. And these are quite plausible situations to contend with, because when we talk about the degradation of our knee, and we go back to our rather crude picture of the knee, then depending on whereabouts on this highly specialized surface that it is, so our articular cartilage kind of looks a little bit like that in terms of where it sits. Doesn't go up quite that far. Depending on whereabouts any damage is, so if we had a region of damage here, then we're going to have a limit to the amount of flexion that we can do, because as soon as you get contact with the lower leg and this region of damage, we're going to have pain. And essentially it would be reasonable to say that where we are trying always to design to maintain or to improve quality of life, the inverse way of looking at it is that we're always trying to reduce or control pain. And so as engineers, we know that there is a time when the knee starts to degrade, 70 years or thereabouts, and so it's a matter of us coming up with solutions that enables people to keep doing these relatively trivial day-to-day activities that actually, if you can't do, has a massive impact on everything else that you want to do. If you can't get out of bed and put your own shoes on, then none of the above can really happen, or can't happen to the degree that someone would reasonably expect them to do so. We also have very subtle movements in the other two planes as well. But I want to talk about this. This is called our gait cycle. And as the name suggests, it's a cycle. It's a repeating activity that you can do. And it's actually describing what happens to our joints when we walk. And here it's useful to kind of note that the right leg has been depicted in yellow, and then the left leg in green. Here, we're having a bird's eye view of the time that each of our legs or our feet are on the floor. So throughout 100% of our gait cycle, so from taking, in essence, one step with the left and right leg and getting to a position where we're back in place to do that again, we have a period of time with our right leg on the floor to a position of what we call toe off. The right leg then swings through to heel strike to get back into the same position again. So whilst the right leg is swinging, the left leg is supporting your body weight because your left leg is on the floor. And this phase is called the single support. So there's a period during any 100% of the gait cycle where you actually have both feet on the floor, but the majority is either one leg or the other leg supporting the entire body weight. And this obviously changes, the proportions change when you run. Also, the loads that go through your joints become greater and greater. But how much movement do we get? So here we're looking at the tibia and the fibula. So, the tibia and the femur. So the main part of the knee joint. And we're looking at it from a position of flexion and extension. So we can see that in the swing phase, we have the greatest amount of flexion. So that's looking at our right leg, our yellow leg. Not an awful lot of flexion happens in the knee up until this point, when you need to pull it from behind you, back through to in front of you, to heel strike, when your heel is on the floor, and then you can bring the left leg through as well. So as you bring your leg through from toe off, which is when your foot initially leaves the ground, through to heel strike, you have a significant amount of flexion. Can be as much as 75 degrees at times. If we consider the other two planes, it's a lot less, from 4 to 13 degrees. And when we're looking at abduction and adduction, less than 5 degrees in total. So flexion and extension is the main thing that we're looking at. So again, we can start to add complexity to our analysis. We can start to predict what happens in more real-life scenarios when, for example, you're trying to measure the joint reaction force going up the stairs. So we can take our more simplified versions from earlier on, and we can start looking at the vectors involved here. And we can, in essence, construct our own free body diagram. Again, we're presuming that being a statics problem, inherently the leg is in equilibrium, so you're not actually walking anywhere. You're in essence stood still on the stairs in this position. But again, this data is useful because joint reaction forces dictate to a great extent the type of materials that you can use if you were to design a joint replacement and the thickness of those materials. Without having any appreciation at all of the joint reaction force, then making those subsequent design decisions will become very demanding. We could, should we wish to, make a person-specific replacement based on this data. So we would know their weights, and we could look at the activities that they do, even if we wanted to look at the power generated by their quadriceps. And we can again follow a process through using vectors to come up with an estimate of the joint reaction force about 4.1 times the force through the foot or our body weight. So simply by estimating somebody walking upstairs, we're coming to a position that they're using, or their joint is transmitting 4 times how much they weigh. So if you were to start designing a new hip or a new knee, and you were to presume the worst case scenario of somebody maybe carrying someone else, and so presuming that they'd have a force of twice their body weight going through their knee, then even something as simple as walking up the stairs would already exceed the boundaries that you designed for. We can again do some moments. We can look at distances between the pivot and the force. And we can come to a position by applying the rules that we did earlier on. So again, the static analysis has great value. A few more slides before we conclude for today. This is the kind of stuff that we're really interested in. Statics is all very well and good, but it's very theoretical. What the clinicians and what the orthopedic companies really value is more realistic data. How can we start to look at what happens when people are moving, when people are climbing the stairs? Not just being stood still on the stairs, but actually wanting to climb the stairs. And so we need to do dynamic analysis. And so we're going to have a few slides just to touch on this today and then invite any questions. But tomorrow we'll be starting to go into this in a lot more depth. So looking at what the muscles and the ligaments and the tendons do in contribution to this field. So static analysis is useful. We don't want to underestimate the value of it, because it gets us the magnitude of a force and a moment of the joint. However, it's rare in biomechanics that you end up with the problem where nothing's moving. We want those examples where people are moving, going back to the earlier images of sports, of orthopedics, where we want to capture what happens when people move and design to improve quality of life in those scenarios. So we need a capability to measure these forces dynamically. And those forces, again, are our body weight. And that body weight changes. It shouldn't be presumed that our body weight stays as is. If we were to drive over a bridge in a car, then we feel lighter and then we feel heavier. If we're on an aeroplane, as it bumps up and down, then we suddenly feel heavier and lighter again. So our body weight, the contribution of our body weight changes. Our muscles and our other soft tissues also contribute to what's happening to the skeletal system. And of course, as does what's happening externally. So if we consider back to that anterior cruciate ligament rupture, we hypothesize that was from some kind of impact from the side. That externally applied load is something that is very difficult to cater for, but something that we need to be able to predict the consequence of. And this, in terms of joint design, is very important. Frictional forces. How do we start to measure friction within the joint and predict the consequence of it? In dynamic analyses, we ignore it, but in other elements of biomechanics, we need very much to factor it in. But probably the two most important points for a dynamic analysis is the consequence of that mass. So the inertia that you generate, the acceleration or deceleration of the body parts. And again, putting this into a context that is perhaps more obvious. If we were to go in our car at 50 kilometers an hour and gradually slow down, then we'll be okay, because our deceleration is controlled and relatively minor. Equally, if we're driving at 50 kilometers an hour and we hit something and stop suddenly, then our biomechanical consequence is going to be a lot different. We're going to come out with injuries to our musculoskeletal system for whatever reason that may be it that we've hit something inside the car, or that the restraint has worked but has caused damage and injury to us elsewhere. So the ability to factor in the inertia and the acceleration, deceleration, the consequences of those are what we'll be focusing on in dynamic analysis. And there are 6 steps that we would ordinarily consider. And these will allow you to calculate the minimum force acting on the joint. We would need to identify the structures that are involved. In particular, the body parts and the main muscles. So if we're looking at trying to simulate an injury in sport, then we would want to isolate, theoretically at least, the parts of the body that are moving and the contribution of those muscles. We then need to start considering the speed by which they're moving. But the speed only gives us part of the picture. We want to consider the acceleration of them as well. Because again, knowing that you're in a car traveling at 50 kilometers per hour is very different to knowing that you were in that car and it stopped within 2 seconds. That time domain adds so much clarity and so much more information to the picture that we're trying to build up. The mass moment of inertia is effectively derived from data that describes where our mass is held. So that, to a certain extent, defines where your fat reserves are and where your muscle stores are. They differ based on gender. They differ based on various other parameters too. But we can determine from the literature, for example, where the center of mass of the arm is, or the torso, or anything else. That is derived from what we call anthropometric data. And knowing those positions, knowing the parameters of inertia, again adds great value to our analysis. Knowing these parameters, we can start to calculate torques. So we can begin to build a far better picture of what's happening in the joint. So we're not talking about just a force. We can start talking in terms that are comparable to other engineering sectors when we look at loads and forces that effectively are around a point. So we're talking about torques and moments. And we're not talking about hypothetical torques or torques when someone is standing still, but we're talking about torque in a dynamic scenario. We can calculate the magnitude of the main muscle force that accelerates a body part. And then ultimately, we can calculate our joint reaction force. Ironically, perhaps, we end up calculating this in almost a static type scenario. But with all of the other parameters that are being fed into it, then we can be confident that this is far more accurate than a static analysis itself. So the last slide for today, before inviting any questions on this, if we wanted to go away and have a practice at implying or applying some of these tricks, then we could try and predict the dynamic activity in the knee joint, the tibiofemoral joint, when kicking a football. And we can do that by looking at the joints involved, by looking at the acceleration of the joint, and by looking at the moment of inertia as well. And so we can feed that data in, and we can come to an answer should we wish to. That concludes the slides for today, but does anyone have any questions on this, which is supposedly meant to set the scene for those lectures to come tomorrow and beyond?
Any questions?
The fibula has a relatively small part to play in the knee. If we were to go back to some earlier pictures, we can see that the insertion of the fibula itself is actually below the knee joint. The forearm is the same as the lower leg. It has a bigger bone and a smaller bone, and it's that which allows the rotation. So the reason that the lower leg has this kind of main load-bearing structure, which is in the middle, or near the midline, and an outer, very thin structure, is to enable rotation. And so were we not to have that second bone, then we wouldn't have the degree of movement that we do. But in terms of its influence on the knee, then we've got a joint here, which is the kneecap and the femur, and then the tibia and the femur as well. The fibula and the tibia are connected. They're kind of bound together by some very fibrous tissue. And equally at the bottom, when we look at the ankle, they're kind of wrapped up again. But there's not an awful lot, well, there's nothing at all that happens in terms of the fibula influencing the knee joint itself. Yes. Yep.
So how do we appear in the center plane? These are like these motions. These must be appearing in the frontal plane.
That's right, yeah. So if we were to consider our ankle, we could have flexion extension of the ankle or the foot in the sagittal plane. But in terms of the elbow, or certainly the shoulder is very difficult, if not impossible, to flex in the sagittal plane. The plane is very much dependent. So the plane always stays the same. So the sagittal plane is always cutting through side to side. And then if you have movement of a particular joint in that plane, then you describe it as such. If the movement of the joint that you want to describe is in the frontal plane, then you would ignore reference to the sagittal plane. That makes sense? So in terms of the action on the picture, going back to that picture, that one there. So I think your point being that that's not in the sagittal plane, but that's in the frontal plane. Yes, no, I'd agree. A better example would be to look at the flexion around the ankle. So you'd have that in flexion extension of the ankle joint is more naturally in the sagittal plane. Yes.
What is the role of synovial fluid in knee mechanics?
Good question. Can you actually see that scribble that I've done on the board? If I go over here, though fearing that it might be out of view. So if we look from the side of the knee, and this is clearly simple but hopefully effective. So this is our femur. And this is our tibia. And we've already kind of accepted that there is a specialized covering on both. This specialized covering is called articular cartilage. So that's a spongy material that has an ability to absorb and then squeeze out fluid. So we have some ligaments, 4 ligaments within there. We need to be aware that these surfaces are a lot closer together. This is clearly somewhat more dramatic than what happens in the joint itself. And then within this space is fluid called synovial fluid. And we need to remember too that this space is effectively wrapped up. So nothing can escape from this space. It's wrapped in 3D in a very tough sheet of tissue. And so the synovial fluid effectively is our engine oil, because this slides backwards or rotates backwards and forwards. So every time you walk, there is movement between either this sliding upwards. So that's when we talk about our 60 to 80 degrees of flexion. And so you have movement between the bottom surface and the top surface. So much like any mechanical system, where you have movement of one surface versus the other, you're going to have wear. And the only way you can really minimize wear is to have some kind of oil in the system as well. And so the synovial fluid serves as the oil. It serves to create a layer between those two surfaces. The trouble is, and we won't touch on this too much now, but there is a mechanical theory called something, and that's called the Strybeck curve. And theoretically, this defines how the lubricant within a system such as this will behave. And the 2 key parameters here are speed versus load. Viscosity is also a part, but we ignore that because it's consistent. So speed versus load. So as the ratio of speed versus load goes up, then this is the coefficient of friction. Then we enter a region of optimal performance. The trouble that we have is that whilst this describes mechanical bearings very well, and people have no real argument with this in the mechanical engineering world, when it comes to applying our theories and concepts onto this trend, it just doesn't work. And so it's unclear quite how the synovial joint behaves as it does, because you get 70 years of life out of it before it starts to degrade. These are 2 very soft tissues. They must be soft because they deform and they move back to their original shape every time you take a step, and so they're very soft. The synovial fluid regenerates, but it's within effectively a watertight space. And there are 4 ligaments that don't really interfere with that process as such, but they all bind it together. And so quite how the role of synovial fluid is achieved as effectively as it is not yet fully understood. People have tried to apply various theories to this trend, and we'll discuss those later on in the week. But I say without much success. They try and find a solution that fits, despite the fact the theory doesn't overlie with the mechanical understanding at all. So I guess to go back to your original question, why does the synovial fluid operate as well as it does? Because it helps to create an optimum condition, though that optimum condition no one fully understands yet, and nor can they replicate either. When we consider this, to reiterate that point, this lasts about 70 years. And yet we look at replacement surgeries by replacing that joint with a man-made component. They've been trying to do that successfully since about the 1920s was when the first one was originated. The maximum we can get thus far is about 20 years. So that's with almost 100 years of research in the biomechanical field happening. Not that it's really been called biomechanics for 100 years, but research within an area that we would now class as biomechanics happening for about 100 years. That's as good as we can get. We've tried to copy these soft materials. That hasn't worked. We've tried various other permutations and combinations of materials. But I say, as of yet, the most success we can get is about a replacement joint of 20 years, because we just cannot fully understand what's happening here, which then limits our ability to go off and copy it with synthetic materials. The synovial fluid is the quantity of it. There is this difficult to imagine that, but in 3D, the whole of this is covered up, is wrapped up by a cloth or a sheath. On the inside of it are cells that produce more synovial fluid. So there's never really a shortage of synovial fluid because you've always got more being produced. And so it's not, if it was merely a matter of having more synovial fluid in this to make it last longer, then people could go along for injections every couple of weeks to inject more synovial fluid. If that was fundamentally the limitation, was the quantity of synovial fluid that was the cause of this limitation, then there would be ways around solving that problem. But whilst the quantity of synovial fluid must be important, it's not yet been found to be the only thing that influences or that can increase that to a level that people are more accepting of. So you can have injections of hyaluronic acid, which effectively is the lubricating component of synovial fluid, but it still doesn't really change that. Yeah, so the important engineering part of synovial fluid is HA, hyaluronic acid, and so that's the important component within synovial fluid. There are various diseases that are known to degrade the quality of synovial fluid. By that we mean the viscosity of it. And there's a test that used to be routinely done. I'm not sure it is anymore, but effectively, if you could get your forefinger and your thumb and you could string out some synovial fluid between it, then you know you had healthy synovial fluid. Not that you could do it yourself, but as a rule of thumb in terms of assessing quality of synovial fluid. If you went to an osteoarthritic patient, someone with a synovial joint degeneration, then you wouldn't get the same viscosity of synovial fluid because you wouldn't be able to string it out between your finger and your thumb. And so synovial fluid is known to degrade in quality in a degrading joint. We know the important lubricating parameter of the fluid. We inject in the important lubricating parameter to try and ease off pain with people whose joint is degenerating. But none of those have yet been combined with the existing replacement solutions to get anything that's above, or certainly nowhere near 70 years. So the proteoglycans in the HA are the important ones. Where they're released from? They're released from the synovium and the cells in the so synovium cells, I suppose, the cells in the synovium.
If we perform gait analysis,
Yep.
and compare the gait with a normal person, like if there is someone with an abnormal gait, we can say that something is wrong with the knee or some other part. Can we predict what is the problem, if it is shortage of synovial fluid or some cartilage degradation?
Probably you wouldn't be able to tell you'd be able to identify someone who's probably got osteoarthritis. Predominantly, you would look at them for a start, and if they're kind of 60, 70 years of age, and they have relatively poor gait in one leg, then unless they've had a sporting injury recently, the likelihood is they've got osteoarthritis. If they're 25 years of age and had one leg that was falling outside of the normal range that's typical of gait motion, then the likelihood is that they haven't got osteoarthritis because they're too young, and they'd probably have some kind of sports-induced injury or some kind of acute injury or defect on the cartilage surface. And so the ability to quantify movement is useful to a point, but if you couldn't see or get a history of that person as well, if you had no idea how old they were or what they've been up to, then those numbers by themselves would only give you so much of the picture, wouldn't give you a complete story. Hmm. We'll come on to that on Thursday, I think. But yeah, in essence, no, they're not. They are kind of standard fits. So much like if something went wrong with your car or with your bicycle, then you would go to a shop and you would buy a replacement component that is pretty much the right size. And so there are different sizes of knee replacements that are available, and you would get the one that is most appropriate for your vehicle, but it wouldn't be one that is made specifically for your vehicle. So they wouldn't laser scan your engine and then manufacture a part to fit your engine precisely. They would get one off the shelf that is for an engine of your type. And so that's kind of what happens here. They'll have a look at the rough size of your knee, and they'd say, okay, you've got a large knee, so we use a large implant. It would be done from MR or X-ray, so they would have a look at the actual size of the knee itself. So as part of the planning process, they would scan the inside of the leg so you can get a picture of the bone and the knee as well. And then they can take measurements from that and say if it's so big, then it falls within the range of a large or a medium or a small knee from a certain company. That there are weights above which you can't have a knee replacement because the likelihood of success versus the risk of the anesthetic for nothing else, that the balance just doesn't weigh well enough in the patient's favor. There's also a risk that if you're too heavy, then you won't be able to do the rehabilitation, or that you would put so much load on a new knee that it just isn't designed to withstand that. Yes. Yeah. So what? And again, we'll touch on this in more detail later in the week. But the selection of materials that you use for a knee joint would have a number of considerations taken into account. So one of which would be the age of the patient. And so where we have problems here of 20 years, now to be honest, there's not all that many solutions or different solutions. If you needed a full knee replacement, then there aren't that many choices in terms of material selection. What they would do, if you only had, so if we look at the knee from the front, if we call that the medial, and that's the lateral, so that's the inside there. So if there was only some damage here, say, then certainly in younger patients, the last thing they would want to do is replace the whole of the knee. So what's more likely is that they would effectively put that they would replace a single of those two condyles. And the reason for that is it's a solution that is likely, by the time you add up the number of years this person has left in their anticipated life, will give them the most favorable outcome. And so that would be a solution to extend the life of a patient. So it very much depends on the circumstance of the patient that's in front of you. Hips have a wider range of materials that can be used. So ceramics are quite popular in hips. But much like any kind of ceramic material, they're very prone to brittle fracture. And so they're very hard, a lot harder than the traditional hip replacement materials. And so if you're a younger patient, then you might go for a ceramic hip because they're likely to last to the upper end of what we could expect a hip to stand for. But the downside is that you end up with a very brittle replacement, and you have to physically be aware of what you do because of the increased likelihood of that replacement failing by a brittle fracture. So going back to your question, there are various combinations of materials that you can use depending on the desired lifestyle that somebody wants, their age, their mass, budgets, and so on and so forth. Okay, thank you very much, and then we've got various sessions tomorrow.